Good morning, consultants, senior registrars, registrars present, medical officers. My name is Dr. Isa Khadija, and today I'll be taking presentation on management of generalized anxiety disorder. Okay, this the outline for the discussion. We'll be taking introduction, epidemiology, etiology, symptoms, diagnostic criteria, comorbidities, differential diagnosis, treatment, complications, prevention, role of family physicians, and then we'll conclude the discussion. Okay. Um, as my way of introduction, it is normal for people to occasionally worry about things, events, and situations. But people with generalized anxiety disorder have excessive worry not supported by a reason, which may affect their daily functioning. Always expecting things to go wrong in the work, family, health, or money. It disrupts their social activities, family, work, or school. So, a lifetime risk of generalized anxiety disorder is 4 to 6%. Then women are more susceptible with female to male ratio of 2 to 1. Then the common age groups affected is 45 to um, 59 years. And only 40% of generalized anxiety disorder receive appropriate treatment. About 45% of generalized anxiety disorder in primary care setting are misdiagnosed. So there are multiple factors for the etiology of generalized anxiety disorder. Um, we have familial factors, environmental factors, and behavioral inhibition factors, and even biological factors. So in familial factors, um, parents usually they model that anxious behavior in their children, and that leads to development of generalized anxiety disorder subsequently. Then environmental factors such as parental emotional disruptions, disrupting attachments, stressful life events, traumatic experience can also predispose a person to having generalized anxiety disorder. Then there's something called behavioral inhibition. It refers to consistent tendency of some children to demonstrate fear and withdrawal when they're in certain situations. So that can also predispose to generalized anxiety disorder. Then for the biological factor, the pathophysiology is not clearly understood. However, abnormal response to stress um, can lead to generalized anxiety disorder. So, if there's different dysfunction of multiple neurotransmitters involving wide areas of the brain, including receptors of benzodiazepines, N-methyl D-aspartate, glutamate, serotonin, and cholecystokine, then neurohormonal altercations and sleep disturbance can also lead to anxiety episodes. Example, if there's abnormalities in brain corticotropin releasing factor secretion and the hypothalamic pituitary adrenal axis, it occurs with anxiety episodes and that can affect the neurotransmissions. Then even genetic and chromosomal abnormalities have also been implicated in generalized anxiety disorder. So they present with physical symptoms such as muscle tension, gastrointestinal discomfort or diarrhea, irritability, fatigue, edginess. They always feel on edge and they're restless with sleep difficulties. Then other physical signs like tachycardia, tachypnea. So in most cases, high index of suspicion will make the diagnosis in most cases. So there are different diagnostic criterias for generalized anxiety disorders. We have the DSM-5 diagnostic criteria. So for the DSM-5, when there is excessive anxiety and worry occurring more days than not for more than 6 months concerning a number of events. So there will be inability to control the worry. Then the anxiety and worry are associated with at least three of six of these symptoms, and then only one of these symptoms is required in children. When there is restlessness, feeling keyed up or feeling on edge, being easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. So the anxiety, worry, or physical symptoms causes clinically significant distress or impairment in important areas of functioning. So the disturbance is not due to physiological effects of a substance or medical conditions, and the disturbance is not better explained by another medical disorder. That's the DSM-5 criteria. Then we also have some tools that we used in screening for generalized anxiety disorder. This is there are other diagnosis tools, but the commonest one used is the GAD-7. That's the generalized anxiety disease scale. So the GAD-7 has been validated as a diagnostic tool and a severity assessment scale with a score of 10 or more, having good diagnostic sensitivity and specificity. The scale was developed and validated based on the DSM-5 criteria, but it remains clinically useful after it was validated by DSM-4, but it remains clinically useful after the publication of DSM-5 because the difference in the GAD diagnostic criteria are minimal. So greater GAD-7 score correlates with more functional impairment. So this is a diagram of the GAD screening tool. Um it has sorry it has some classifications here, some questions. There are 7 questions, hence the names of the name GAD-7 screening tool. So um you ask the patient, over the last 2 weeks, how often have you been bothered by the following problems? So not at all is 0, several days is 1, more days than not, more than half the days is 2, then nearly every day is 3. So you tick based on the response of the patient. So 1 is, are you feeling nervous, anxious, or on edge? So is it not at all? Is it on several days, or more than half the days, or nearly every day? Then not being able to stop or control worrying. Is it not at all, several days, more than half the days, and nearly every day? Then worrying too much about different things. Is it not at all, several days, more than half the days, and nearly every day? Then trouble relaxing. Is it not at all, several days, more days than not, or nearly every day? Then being so restless that it is hard to sit still. So to be scored just like the others. Then becoming easily annoyed or irritable. That will be scored like the other questions. Then feeling afraid as if something awful might happen. You ask, is it not at all, several days, more than half the days, or nearly every day? So the total score for the 7 items ranges from 0 to 21. Scores of 5, 10, and 15 represents cutoffs for mild, moderate, or severe anxiety. So if the patient has 5, then has mild anxiety, moderate 10, a score of 10, then 15 severe anxiety. Although it has been designed primarily as a screening and severity measure for GAD-7. GAD-7 also has moderately good operating characteristics for panic disorder, social anxiety disorder, um, post-traumatic stress disorder. When screening for anxiety disorder, a recommended cutoff for further evaluation is a score of 10 or greater. So if you have a patient with a score of greater than 10, you will want to further evaluate the patient. So how do you assess the patients that you're suspecting for generalized anxiety disorder? So you do a mental status examination. You check the appearance of the patient. How is the patient presenting? Is the patient well kept? Is the patient anxious? Is the patient maintaining eye contact? So you ask about the mood. The mood is sustained emotion that affects that the patient is experiencing. So it's you ask questions like, okay, how do you feel on most days? What's your mood in most days? Are you happy? Do you feel sad? Do you feel on edge? And all that. Then the affect, you check the affect. The affect is what you notice from the patient. What's the patient's immediate expression? Is the patient euthymic? That is the patient normal? Is he constricted? With limited variations in expression, or is the patient blunted? That means there's minimal variation, or flat, there's no variation completely. Then you also assess the speech of the patient. How fast or how slow is the patient talking? Is the patient raising their voice? Then are their replies one-ended questions? So you also check for the thought content. You determine if the patient is having hallucinations or delusions. So clinical interviews are usually conducted when assessing the patient. Multi-method approach, especially if it involves the child. So you bring the child, the parents, and the teachers, and then have like a clinical conferencing and discuss um what is possibly leading to the child's anxiety. Then three primary ways anxiety presents are assessed. Is it behavioral, thought, or somatic symptoms? Then semi-structured diagnostic interviews can also be assessed. So usually um generalized anxiety disorder is a clinical diagnosis. However, if the diagnosis is not clear, you want to do some investigations to rule out some differential diagnosis. You can do a full blood count if you think the patient has anemia. You can do a thyroid function test if you suspect hyperthyroidism. Then you can also do HIV screening in case you're thinking it's probably HIV. Then fasting blood sugar in to rule out hyperglycemic or hypoglycemic emergencies. Then ECGs, arrhythmias, chest x-rays to check for cardiomegaly. Then you also do a urine toxicology to exclude drug abuse, because in some patients with drug abuse they can present with anxiety. So comorbidities. Um Generalized anxiety disorder tends to exist with other psychiatric disorder. It can include major depression, bipolar disorder, anxiety, and substance abuse problems. So many similarities exist between depression and generalized anxiety disorder, necessitating suggestion of recategorization of generalized anxiety disorder as mood disorder. So because of the similarities, have even been considerations in recategorizing generalized anxiety disorder as a mood disorder. So, what are the differential diagnosis? It can be anxiety as a result of organic cause, then anxiety triggered by a specific situation, then normal anxiety in response to stress, then other anxiety disorders such as panic disorders, phobias, obsessive compulsive disorder, post traumatic stress disorders. Then major depressive disorders, schizophrenia, anxiety associated with drug and alcohol abuse. So some patients with symptoms of withdrawal from alcohol, benzodiazepines, cocaine, marijuana, and selective serotonin reuptake inhibitors can actually present um, with symptoms of generalized anxiety disorder. Then certain stimulants such as amphetamines, asthma medications, and caffeine can also produce anxiety. So um, some of the we'll look at some of the other anxiety disorders. Social anxiety disorder. In social anxiety disorder, also known as social fear phobia, there is marked fear or anxiety about social situations in which the individual is exposed to possible scrutiny by others. Examples include social interactions. So if such patients find themselves in social interactions where they're being observed or performing in front of others, they tend to have marked fear and anxiety. The individual feels that he or she will act in a way or show anxiety symptoms that be negatively evaluated, which will be embarrassing and lead to rejection or offend others. So symptoms of there will be symptoms of sympathetic overactivity such as tremors, palpitations, and sweating. Then obsessive compulsive disorder. Obsessions are recurrent and persistent intrusive ideas, thoughts, impulses, and images, while compulsions are repetitive, stereotype behaviors in response to an obsession to prevent discomfort or some dreadful event with which is not connected in a realistic way. Like patients that tend to feel okay, they have germs on their hands all the time, so they have the compulsion, they keep washing and washing and washing their hands, making it distressful. Then panic attack is another differential diagnosis. So panic attack is a discrete period of intense fear or discomfort in which more than four symptoms develop abruptly and reach a peak within 10 minutes. So such symptoms can include palpitations, pounding heart, accelerated heartbeats, sweating, trembling, shaking, sensation of shortness of breath or something, feeling or smothering, feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, derealization or depersonalization, then fear of losing control, going crazy, the fear of dying, paresthesia, chills or flushes. Then post-traumatic stress disorders, when three clusters of symptoms persist for greater than 1 month after exposure to a traumatic event. So there's intrusive phenomenal recollections, nightmares, and flashbacks. Then hyperarousal phenomenon, exaggerated or subtle response or irritability. Then the avoidance of reminders and emotional numbing. So for a specific phobia, they have fear of a particular object or situation which is out of proportion to the apparent stimulus, cannot be explained or reasoned with, leads to avoidance of the object and situation. The four subgroups are, so they can be afraid of animals such as dogs, birds, or moths, then natural events such as heights, storms, water, or lightning, blood or injury or infection, fainting at the sight of blood, having an injection or blood sample taken, then situations as aeroplanes, lifts, and enclosed spaces. So we also discuss about pediatric generalized anxiety disorder. There's excessive worry about a variety of events accompanied by physical symptoms, headache, tension, restlessness, GI distress, and palpitation. These symptoms impose marked distress and interfere with the child's social, emotional, and educational functioning. The focus of the worry could change, but worry may persist. Then 10%, um, it affects 10% children and adolescents. Average age of onset of generalized anxiety disorder is 8.5 years. Then it affects more girls than boys and commonly occurs with separation anxiety and social phobia. So the treatment of generalized anxiety disorder, you can have non-pharmacological treatment and pharmacological treatment, or a combination of both. Then other modalities of treatments like cranial electrotherapy stimulation. So the non-pharmacological measures of treatment, it includes cognitive behavioral therapy, which includes um, psychoeducation, tackling stressors, reducing stress, encouraging physical activity. So, cognitive behavioral therapy approach is most effective and beneficial treatment of generalized anxiety disorder. So, there is 50% positive clinical response to cognitive behavioral therapy. Patients on CBT show reduction in anxiety and depression. And then combining medication and psychotherapy is usually more effective for patients with moderate to severe symptoms. The establishment of a therapeutic alliance between the patient and the physician is important to allay fears of interventions and to progress towards treatment. So, the non-pharmacological measures, the cognitive portions assist changes in thinking patterns that support fears, whereas the behavioral portion often involves training patients to relax deeply and help desensitize patients to anxiety-provoking triggers. To be effective, therapy must be directed at the patient's specific anxieties and tailored to his or her needs. There are minimal adverse effects except the behavior desensitization is typically associated with temporary mild increase in anxiety. Another non-pharmacological measures is mindfulness-based stress reduction. The intervention promotes focused attention on the present, acknowledgement of one's emotional state, meditation for further stress reduction and relaxation. Key features include non-judgmental attitude, formal meditation techniques, and daily practice. Then addressing current psychosocial stressors. So common lifestyle medication that may reduce anxiety related symptoms include identifying and removing possible triggers, e.g. caffeine, stimulants, nicotine, dietary triggers and stress, improving sleep and improving sleep quality, quantity, and physical activity. The importance of continuing as far as possible activities that used to be interesting or give pleasure. Then structured physical activity program organize is another modality for non-pharmacological methods. Um, Organization of physical activity of moderate duration, that's for 5 minutes, times per week. Start slow and gradually increase. Exercising at 60 to 90% of maximal heart rate for 20 minutes 3 times weekly has shown to decrease anxiety. Yoga is often very effective. So, prognosis is good if treatment is started early. 80% recovery rates during 3 to 4 years follow-up period, increased risk of developing other anxiety disorder, and then there is high risk of comorbidity with depression. Then the pharmacological methods, we have the selective serotonin reuptake inhibitors. They are generally considered safe first-line therapy. Then tricyclic antidepressants are now considered second line due to risk of side effects. Then the dose of antidepressants that are used is usually half the dose of what is used in depression. Then monoamine oxidase inhibitors such as phenylazine are complex drug to use given their potentially fetal drug and dietary interactions, and should not be prescribed in family medicine settings. So here are some of the medications. We have the selective serotonin reuptake inhibitors, then examples the escitalopram, fluoxetine, paroxetine, and sertralin. Here are some of the doses and then the side effects: nausea, diarrhea, vomiting, sexual dysfunction, headache, insomnia. Selective serotonin reuptake inhibitors have been used to treat premature ejaculation, and should be aware of suicide risks when used in those age less than 18 years. Then tricyclic antidepressants as amitriptyline, nortriptyline, um, they cause dry mouth, constipation, blurring vision, orthostatic hypertension, weight gain, solemnness, headaches, sweating, and sexual dysfunction. So use in caution in those who have cardiac conduction issues. Use cautiously in elderly due to risks of falls, and can be used for in patients with migraine. So then benzodiazepines can also be used as diazepam, lorazepam. They should be used concomitantly with selective serotonin reuptake inhibitors for anxiety and short-term use in panic disorders. The side effects include sedation, fatigue, ataxia, speech, memory impairment. And there is risk of dependence and abuse, especially with short-acting benzodiazepines like lorazepam. Some other medications as pregabalin, mirtazapine, and beta blockers are also used. So, monitoring treatment, monitor the effectiveness of treatment. Usually, treatment takes 9 to 12 months to be considered for discontinuation. Assess need for further titration of medication 2 to 4 weekly as drugs take duration of onset. Then assess increased irritability or worsening of symptoms or non-improvement of symptoms. Assess adherence to medication regimen. Assess for medication side effects, continuation. Continue to emphasize nutrition, physical activity, and caring for self. Minimize complexity of medication using. Then when to discontinue treatment, um, when there is remission of symptoms for 6 to 12 months, tapering of medications rather than abrupt seizure, then physicians should discuss the early warning signs of relapse and instruct patients to contact their physician if such symptoms reoccur. The risk of relapse is greatest in the first few months of discontinued medication, and thus a scheduled appointment in this period is often needed to monitor relapse. And patients who relapse after cessation of medication should be restarted again. Complications, comorbid depression or other comorbid conditions, cold truancy and withdrawal, strained family relationships such as child irritability, non-compliance, demanding behavior, chronic reassurance seeking, self-medication leading to substance abuse, parents' inability to help in the child's treatment or model adaptive coping, anxiety management because of their own untreated anxiety. So, prevention of anxiety, consistent, stable, supportive home environment, parenting practice that promotes self confidence, self esteem, and effective coping skills, minimal number of psychosocial stressors or traumatic events, adaptive problem solving and coping skills modeled by parents and other significant people in the child's life, psychoeducation, and family based interventions. So, indications for referral to a psychiatrist if there's poor response to treatment, if there's atypical presentations, physicians inexperienced with treatment modalities, and concerns for significant comorbid psychiatric illness like suicide. What are the roles of family physicians as the caregivers? Caregiver, where the first contact with the patient, we have to make appropriate diagnosis with use of appropriate family medicine tools for patient-centered approach. As the coordinators of care, we coordinate care and involve other medical colleagues, and then we also refer when appropriate to psychiatrists. Then communicator, we help health promotion and prevention of such cases. Then, as an advocate, we identify value and beliefs of the patient and recognize the impacts of the patient's problem on the family. And they also have regards to cost effectiveness. Then, as resource manager, allocation of scarce resources. Then, as researchers, we make research on such cases. Then, in conclusion, generalized anxiety disorder is a common disorder that presents in primary care settings. Treatments are usually a combination of both pharmacological and um, psychological therapy. The prognosis is good provided that treatment is started early. About 80% of generalized anxiety patients recover. So these are my references. Thanks for listening. Should pause.